This
Yes, sir.
conference will now be recorded.
Yes, sir. Audible.
Okay. Good morning, all. So, I think today is the last topic for your year. By completing this topic, the year topics will be completed. So, I hope you have all the notes. Means you might have written notes, or you might have taken down the topics which have been covered. Kindly, if any one of you has it, please, if you have a book, Dingra or some Hazarika book, kindly make a note of it. If any topic is left out, please let us know by tomorrow, by today evening or tomorrow. If you let us know, then next week we will cover those topics, and if everything is covered, then we will start the revision. Means we'll take up the first surgeries, surgical topics once, and then most probably by November we can start our revision. Or else if you want some topics to be repeated, you can just tell us now. So those who have all the topics, if anyone has noted down, please once check your notes and your textbooks. If any topic is left out, please let us know so that we can cover it in the next week, and we can start the surgical part, and later on in the from at least November to December. If at all you're not being called here, then we have to start your revision, so that if as such there is no postponement of any exams. The exams will go as per schedule. So you have to write your exams in I think uh, Jan or February. So definitely you need to be ready for that. Okay. So if I'm audible, then I'll start this class today. The last topic of year, tinnitus. So what is tinnitus? It is one of the ear complaint. As we already discussed once, that there are some cardinal symptoms, right? For all the patients who come with ear complaints, they'll come with discharge, they'll come with ear pain, they'll come with hearing loss, and sometimes they come with tinnitus and vertigo, right? So tinnitus is one of the complaints, chief complaints of some of the patients. So tinnitus stands for the perception of the sound, might be ringing or noise, which has no external stimulus. Like there should be some external stimulus, right? Now I'm speaking, or else if an object is there, like a tuning fork, if you vibrate it, then a sound comes. So there should be some external stimulus. But when there is no external stimulus and still the patient is perceiving some kind of sound, that is known as tinnitus. So tinnitus stands for the perception of sound, which might be ringing or noise type or buzzing type or hissing type, anything. It's the abnormal perception of the sound which has no external stimulus. You need to remember that when you write that there is no external stimulus, that will correlate with tinnitus. When if there is some external stimulus, then definitely there is no point discussing that as tinnitus. So it may be buzzing type, ringing type, clicking type, or escaping of steam like hissing from a pressure cooker, whatever. So some abnormal perception of the sound with no external stimulus is defined as tinnitus. And usually it is unilateral, but may also affect both ears. If it is affecting both the ears, and it's very troublesome for them. But generally it is unilateral in nature. And tinnitus is more annoying in quiet surroundings, particularly at night when the masking effect of the ambient noise from the environment is lost. Generally, when the patients come to you telling that I'm able to hear some ringing sound continuously, then you need to ask them whether it is generally more in the nights when the surrounding climate very silent, when they are in the bedroom sleeping, then they hear the sound more. Because generally what happens is when you are in traffic or when you're in the morning, with all the sounds surrounding environment, like the honking of the so when you have you have a lot of distractions in the morning. Okay, so you have a lot of sound. The fan sounds are there, or the surrounding vehicle sounds, industrial sounds, whatever. So much of sounds will be there. So in that sound, you might that patient might not be able to perceive this sound, but once when it is surrounded by a calm environment, then he might definitely observe that sound. So it is generally more particularly at night when the masking effect of the ambient noises from the environment is lost. So I hope this is clear. There are various classifications, but the most commonly described is this one. There are two types of tinnitus. One is subjective type and is objective type. And sometimes we also describe it as pulsatile tinnitus or non-pulsatile tinnitus, and there's some other type. But generally, in most of the textbooks and most of the literature, we describe the tinnitus as two, that is subjective and objective. So subjective tinnitus is the one which is heard by the patient himself, while objective tinnitus may be heard by examiner if amplified sufficiently. See, when the patient comes to you and let's say he is having the ringing sensation of the ear, of the left ear, and you are not able to hear it, means the examiner is not able to hear it. Only the subject hears the sound. But sometimes what happens is, due to some various reasons, the sound which is heard by the patient can also be perceived by the examiner when amplified. You need to amplify that sound. So that means how can you amplify it? You can use the bell of a stethoscope to hear that. I'll describe some of the causes which are generally objective in nature. So it is two types. Subjective is the one when only the patient is able to hear. Objective is when it is if amplified significantly, the examiner can also experience the same sound which the patient is having. Okay. So it's this is the sagittal section of a ear, through which we can try to understand what are the various causes. Okay, so first we'll start with the external ear. So external ear 4A, that is the wax or some cerumen. When the external ear is blocked, some patients might perceive it as tinnitus, and this is only one condition of the external ear. But then as you know, this is the tympanic membrane, this is the whole the middle ear, this is the external ear. Okay, so this is the external ear, and this is the middle ear, the red one, the red colored shade is the middle ear, and this semicircular canal, this cochlea is the inner ear, and this is the auditory nerve. Okay, so the external ear condition is wax or cerumen, impacted wax, that will cause. Then coming to the conditions of the middle ear, you can see that one of the condition is 5B, that is glomus jugulare. When this is the glomus jugular bulb, this is the jugular bulb area which forms the floor of the middle ear. If you have a tumor, so that can also cause you abnormal perception of the sound. Okay, and this is 6A, which is muscular contraction of the stapedius. When there is abnormal contractions of the stapedius muscle, then also the patient might hear abnormal perception of noise. Okay, and some more conditions like serous otitis media, that is 4B. Whereas 4B, this is 4B. So when the whole middle ear is filled with some secretions and there is no proper movement of the tympanic membrane, that can also be perceived as a tinnitus and abnormal sensation. So serous otitis media is also a condition of the middle ear which can cause tinnitus. Then most of the conditions related are generally inner ear, and there is one more 4C, where it is 4C. This one is a 4C. Okay, 4C is at the area of foot plate due to the stapedial otosclerosis. Okay, so 4A is an external ear one, 4B serous otitis media is a middle ear condition, then 5B, which is glomus jugulare, and 4C, that is stapedial otosclerosis. Then recently we have discussed one Meniere's disease, that is the cause of the inner ear, right? So in the Meniere's disease we had 4 symptoms: spontaneous recurrent vertigo, tinnitus, oral fullness, and sensorineural hearing loss. So tinnitus is also one of the feature of Meniere's disease. So Meniere's disease can also cause, it's a condition of inner ear which causes tinnitus. So Meniere's disease, acoustic trauma, some trauma to the inner ear, labyrinth, will definitely cause tinnitus. Acoustic neuroma, this is 3A. When there is some tumor at the vestibular 7th and 8th nerve, then that will also cause tinnitus. 3B central causes, when there is some problem at the cortex of the cerebrum, then that will also, the auditory pathway, there is some problem at the auditory pathway, that will also perceived as a generally as a tinnitus, abnormal perception of the sound. Impacted wax, serous otitis media, streptococcus otosclerosis, cochlear otosclerosis. If you have a cochlear otosclerosis, then also it might perceive as an abnormal sound. Glomus muscular contraction, glomus tympanicum, which is 6B. Glomus tympanicum. Okay, so glomus tympanicum will also sometimes cause that tinnitus, atherosclerosis. This AV malformations are 7B. Where is 7B? Here. Some AV mal. This is the sigmoid sinus. Okay, so when you have some problem at the sigmoid sinus level, and 7A is atherosclerosis. So these are conditions of related to the blood vessels. So these blood vessels, when they have some problem, that is known as that can also be perceived as abnormal perception of sound. And these are some of the objective causes. When you keep a bell of the stethoscope at the sigmoid sinus area, at the mastoid and the occipital area, you might hear some sound. When you need to amplify it, right? So these are some of the atherosclerosis, glomus tympanicum, glomus jugular, AV malformations. These are some of the conditions where you can hear. So these are the examples of objective tinnitus, whereas all the other conditions are subjective. But the conditions like atherosclerosis, AV malformations, glomus jugular, glomus tympanicum, all these are subjective type of objective type of tinnitus, where the examiner can also hear with some proper amplification. So we will just rush it up now. Only these are the causes. Number one is due to the changes in the cochlear hair cells of the basal turn, which may be like escaping of steam or like ringing of the bells. They may be caused by noise trauma, means when barotrauma, like means when abnormal loud sounds, when you go near a big loudspeaker, due to that there is some pressure difference, and there is some trauma to the middle ear or the inner ear, so that will also cause them tinnitus. Presbycusis, that is sensorineural hearing loss, as age related. Mostly in the 5th and 6th decades, the old people will have definitely some sensorineural hearing loss that will cause them tinnitus. Toxic changes like because of some drugs like salicylates, quinine, streptomycin, neomycin, ibuprofen, imipramine, and heavy metals. So these are some of the toxic causes which can also cause tinnitus. Head injury causing labyrinth and concussion. Ischemia caused by hypertension or atherosclerosis or vasomotor. So ischemial causes can also cause tinnitus. Number two is physical distortion of the cochlea, which may be due to Meniere's disease, endocrine disturbances such as hypothyroidism, diabetes, and premenstrual tension. So all these conditions, when there is a physical distortion of the cochlea, that can also rise as cochlear tinnitus, cause of tinnitus, and it gives rise to roaring, humming, and bell-like low-pitched tinnitus. Disorders of CNS. In this type, other effects of CNS disease are also present. This is generally high-pitched tinnitus. So when there is a physical distortion of cochlea, that is a low-pitched tinnitus. But when the conditions are related to CNS, when the cause is CNS, then generally it is a high-pitched tinnitus. The causes may be CP angle tumors like acoustic neuroma and cerebral atherosclerosis as in old age. So these are generally high-pitched tinnitus. Number four, due to the change in the sound conduction, like due to impacted cerebrum, foreign body atresia, say secretory otitis media, otosclerotic focus. So all these are the causes. How they cause tinnitus? Due to the changes in the sound conduction. So you need to remember this. Okay, the one is due to the changes in the cochlear hair cells. These are the causes. Noise trauma, presbycusis, toxic causes, head injury, ischemia. Physical distortion, like in Meniere's and endocrine disturbances, they are low pitched. Disorders of CNS, they are generally high pitched, CP angle, and cerebral atherosclerosis. Due to the change in the sound conduction, impacted cerebrum, foreign body atresia, secretory otitis media, and otosclerosis. These are the conditions. And number 6 is muscular contraction of the tensor tympani or the stapedius muscle. So these can also cause. Number 5, vascular causes produce pulsatile tinnitus. I was telling you some conditions like AV malformations and all, right? So due to the carotid body tumors, glomus jugulare, glomus tympanicum, otosclerosis, severe anemia. So all these are generally causes of objective tinnitus, where the examiner can also hear due to significant amplification. Some psychogenic causes will definitely cause tinnitus. They are like depression, anxiety. Medullary tinnitus is low pitched, while cochlear tinnitus is high pitched. So the important points to be remembered are medullary tinnitus, when it is due to secretory otitis media or otosclerosis like that, then definitely it's a low pitched one. But when the inner area, when the cochlear hair cells or the inner ear labyrinth, these are involved, then they are high pitched. Pulsatile tinnitus is seen in ASOM, barotrauma, and glomus tumors. And tinnitus synchronous with respiration is seen in patulous eustachian tube. When the eustachian tube is patulous, means eustachian tube gets opened up and closed due to the action of tensor vela palatini and levator vela palatini muscles. But if they are lax, and when we are breathing and inspiring and expiring, if that muscle's contraction is not that out, means if it's very lax, then the patella eustachian tube also will open and shut during the inspiration and expiration. So that will also cause some abnormal, means that escape of the air, escape of air towards the middle ear. So that can also cause some tinnitus. So medullary tinnitus is low pitched, while cochlear tinnitus is high pitched. Pulsatile tinnitus is seen in ASOM, barotrauma, and glomus tumor, and tinnitus synchronous with respiration is seen in patulous eustachian tube. So we have categorized the causes into 7. So the first one was due to the change in the cochlear hair cells. The second one was physical distortion of the hair cells of the cochlea. The third one was CNS conditions. The fourth one was due to changes in the sound conduction. The fifth one was due to the vascular causes. Sixth as muscular contractions, and seventh is psychogenic causes. So these are some of the causes which can cause tinnitus. So this is how generally due to the psychogenic causes, means the patient will be under stress and he will be fatigued, means due to the fatigue, as the patient is in stress, he will feel a lot weak and fatigued. That will cause some depression, and then the patient will have tinnitus feeling. But it's a circle actually. Sometimes the patient will start having means the feeling of tinnitus, that will cause a lot of stress to him, that will lead to fatigue and then depression. It can start with depression, that might present as feeling of the tinnitus, then stress, then fatigue. So everything is a circle, 360-degree circle, where the symptoms can start at any point, but ultimately the patient will have all these things: the stress, fatigue, depression, and feeling of the tinnitus. This, due to the anxiety and the depression, the patient might have feeling of the tinnitus, abnormal perception of the sound without any external stimulus. So what are the causes of objective tinnitus? Patulous eustachian tube, which may follow rapid weight loss or section of the nerve and excessive scarring of the palate, or also stenosis or aneurysm of the carotid artery or its branches can cause tinnitus synchronous with pulse, palatal myoclonus, glomus jugulare, venous hum, AV malformation. So these are all the causes of objective tinnitus. You need to remember them, because sometimes these can be asked as a 2 marks question. Just describe what are the causes of objective tinnitus. Only 5 or 6 you need to mention. So you have to remember this. As such, it's the tinnitus has been described since ages, but still the pathology, the etiology has been described well, but still we are not very clear about the pathology. How does the patient will feel this? What is the reason behind this tinnitus? So the exact etiology and pathophysiology of non-pulsatile subjective tinnitus are poorly understood. Well, when pulsatile objective tinnitus, we know that due to some AV malformation, due to the glomus jugulare, the patient is having it, so we are able to categorize it. But pathophysiology of a non-pulsatile subject to tinnitus, which only the patient is able to hear. We are still not clear how does he hear. Whether the tinnitus is generated by cochlea or due to the cochlear nerve or CNS, it is not known. And the current evidence suggests that it is generated in the CNS. But generally, this abnormal perception of sound is it's a sensory thing, right? So sensory things are carried out by nerves. So most likely it is due to the some disorder of the central nervous system, which might be the cause of the tinnitus is presumed. There are two factors generally suggested. One is deprivation of the input or abnormal input from the ear. It can be either way. Okay, so that ear means it can be from the ear towards the CNS, or deprivation of the input means there is no input from the CNS, but the patient is hearing it, or else there abnormal input from the ear. Maybe some stimulus has been given by the ear, which generally is not given, is not there, and that is perceived by the CNS as an abnormal sound. So one is deprivation of the input, means there is no input from the brain. One is from the peripheral, that is abnormal input from the ear. So these are suggested. Neuronal plasticity and changes in the neuronal input may result to follow structural and or functional changes. Changes in the nuclei of the ascending auditory pathways or redirection of the auditory input to extra auditory pathways. So these are all presumed. There is nowhere proved that these are the causes. This is the pathophysiology there due to which the patient is hearing the tinnitus, but these are presumed. The two factors are deprivation of the input and the abnormal input from the ear. And due to the neuronal plasticity and changes in the neuronal input, may result structural or the functional changes. So what are the changes? The changes, they can be change in the nuclei of the ascending auditory pathways, and they can also be redirection of the auditory input to the extra auditory pathways. Okay. So remember this. So if you are asked about the pathophysiology of the tinnitus, you need to write neuronal plasticity and changes in the neuronal input. That can be changes in the nuclei of the ascending auditory pathways or redirection of the auditory input. It can be either way. How do you investigate? You investigate, the patient comes to you and you take a detailed history. Well, how means how does it start? When do you experience it more? What times it is disturbing you? You also prepare a questionnaire to him and you give it to him to answer whether doing what kind of activities the patient is able to hear it more, where to describe it, and to know the severity of the tinnitus. So they are given some questions, and they have to mark it like there'll be a scale provided 0 to 10. 0 is like very not very much troublesome, and 10 will be like it is very troublesome. So there are some scorings, tinnitus scores will be there, and they have to answer it. Based on that, if it is not troublesome to the patient, then we can manage him accordingly. If it is very problematic to him, then we have to think in the ways in how to manage these cases. Okay, so detailed history along with general and ENT examination is very important for any patient coming with tinnitus complaint. Then you have to have a complete hemogram, fasting blood sugar or lipid profile, serological retrosyphilis to rule out the other general causes which can cause tinnitus. Putative audiometry to evaluate whether the patient is having any sensorineural hearing loss. We do a putative audiometry, impedance audiometry to know whether the patient is suffering with ASOM or any secretory otitis media, serous otitis media. Vestibular examinations to rule out any labyrinthitis features if the patient has any labyrinthine trauma or due to some like that. So to evaluate all those things, we do putative audiometry, impedance audiometry, and vestibular examination. Speech discrimination score and speech reception threshold are also done to evaluate to know whether there is any sensorineural hearing loss or any cochlear hearing loss is there or not. We also do a tinnitus matching electronystagmography and computed tomography scan of the CP angle. So if there is an acoustic neuroma, then you have to rule out, right? So all these are done. You have to take a detailed history. You do a routine blood investigations. You do a putative audiometry or impedance or a vestibular examination. Speech discrimination score and speech deception threshold are tested. Tinnitus matching electrophorestromography and computed tomography scan of CPN. What are the radiological imaging and their indications? We sometimes, when we are suspecting some objective type of tinnitus, we do a carotid ultrasound, vascular pulsatile tinnitus in atherosclerotic disease to rule out. CECT is done so that vascular such as paraganglioma or aberrant carotid or persistent septal artery. So to know all these things, we also go for a CECT. MRI is done to rule out myoclonus or to evaluate multiple sclerosis, because that is also a cause of pulsatile objective tinnitus, right? Gadolinium enhanced MRI due to some CPA angle tumors or SNHL due to some internal acoustic meatus. If there is tumors related to that, then we also do a gadolinium enhanced MRI. MRA and MRV are done to know the vascular abnormalities during dural in AVFs, and conventional angiography is done to observe presence of bruit in case of normal CT or MRA. If you have done CT and MRA, everything is normal, then you also go for a conventional angiography to know some atherosclerosis in the large vessels. So these are some of the radiological imaging and their indications. And the last part is treatment. The patient has come to you, you have detailedly taken the history and you have done all the investigations, and now you know that whether the patient has is a pulsatile tinnitus or non-pulsatile tinnitus, or a subjective tinnitus or objective tinnitus. So if it is due to an objective tinnitus, you have to treat that cause. If it's a myoclonus, then you have to treat the myoclonus. If it's a jugular tumor, you have to treat the jugular tumor. If it is due to atherosclerosis, then you have to do some treatment regarding that. But so treatment of the cause is most important and depends upon whether the subject tinnitus is troublesome or non-troublesome. If the patient, as I said, we give them a questionnaire to answer, and after that, if according to the scores given by the patient, as it's a self-filled questionnaire, right? So we are not forcing him. He is answering according to his symptoms. So if it is not troublesome, not much troublesome, then what we can do is we can give him some counseling, and we can give him a reassurance that, see, it's not a bigger problem. You can overcome it. Just feel that you're quite normal. You can just counsel him. So reassurance to the patient and counseling is done when it's not troublesome. And conservative treatment can also be given, such as ischemia is also one of the cause of the tinnitus, as we can give some vasodilators, as we used to give for vertigo, right? Due to in vertigo also we used to give vasodilators, sedatives. So we can also give the same condition, same drugs to this condition as we used to give in menias. So conservative treatment such as vasodilators, sedatives, vitamins and tranquilizers, and sometimes tokenide is the latest drug used for treatment. Tokenide, zinc therapy is also given, carbamazepine, because some of the patients are due to psychogenic causes, right? So antidepressants, clonazepam and ginkgo biloba has also been used. So all these are conservative treatment: vasodilators, sedatives, vitamins, tranquilizers, tokenide, zinc therapy, carbamazepine, clonazepam, and zepam and ginkgo biloba. Then comes the surgical treatment. When you understood that it is due to some venous disease, then you do endolymphatic sac decompression. When you understood that there is some trauma, there is some inflammation of the inner ear, then you can also give intratympanic injection of alcohol or steroid. Cochlear hair cells are distorted, then you can do cryotherapy for cochlear destruction. Cochlear nerve section if no hearing. If it is a non-serviceable ear, if the patient has no auditory inputs from the ear, then there is no point keeping in that. So you can directly remove the cochlear now. So that will also help in relieving the tinnitus. So these are some of the surgical treatments. And if the presbycusis is the cause of tinnitus, then what you do is hearing improvement. You have to prescribe the patient a hearing aid which improvises and gives psychological effect, as patient believes tinnitus to be cause of hearing loss. So hearing aid. can also use some tinnitus maskers such as continuous, complete or partial, inhibitory or desensitive. There are some products available in the market. They will mask the tinnitus. And if no cause is found, these are quite helpful, such as putting a ticking alarm clock close to head, or a very light soothing sound or music of radio through a headphone, just to make the noise which may be disturbing the sleep. Means some of the patients will only have problem while sleeping when the surrounding environment is very calm. So what you can do is some ambient sound, means, as the surrounding is very calm, you just try to provide some noise, like you can keep a wall. Previously we used to have some wall clocks, bedtime clocks, right? So you can keep it, alarm clocks. You can keep it near the ear, means aside your bed, and that tuck, 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 that sound will be coming from that. So that will help him. Means that sound will be perceived by the auditory nerve rather than by the that tinnitus sound. Or you can also keep it as a small radio at a small voice volume, or earphones using some music, so that will also help him. And psychological treatment of tinnitus includes the following: cognitive therapy, relaxation training therapy, and biofeedback therapy. So all these are some of the psychological treatment of tinnitus. Okay. So this is the topic tinnitus. Most probably you won't be asked much questions from this, but you just need to remember only few points. Mostly the causes are important and treatment part is important. Nothing much. So I hope you have understood the topic. Briefly, I will tell: tinnitus is abnormal perception of sound. It is usually unilateral, and it is observed more while the surrounding is calm. Subjective and objective tinnitus. Subjective is only the patient will hear. Objective is when examiner can also hear when the amplification is done significantly. These are the various causes. We have categorized into 7. The first one is due to the changes in the cochlear hair cells. The second is physical distortion of the cochlea. Third one is disorders of CNS. Fourth one is due to changes in the sound conduction. Fifth is vascular causes. Sixth is muscle contraction. And seventh is the psychogenic cause. Generally, the middle ear tinnitus is low pitched. Inner ear tinnitus is high pitched. Pulsatile tinnitus is seen in ASOM, barotrauma, and glomus tumor. So this is the cycle of the psychogenic causes of tinnitus. So some of the causes of the objective tinnitus are palatalization tube, stenosis, patellus myoclonus, glomus jugular, venous hum, and AV malformations. Etiology is unclear, but you need to remember only 2 points. It can be due to deprivation of the input or abnormal input from the ear. And how to explain that? Neuronal plasticity and changes in the neural input is the explanation for the tinnitus. That is, change in the nuclei of the ascending auditory pathways or redirection of the auditory input to the extra auditory pathways. So these are some of the causes. Pathology. How do you investigate? We do a lot of investigations to rule out various causes of the tinnitus. Radiological treatment is, if it's not troublesome, you will counsel the patient and give reassurance and give the conservative treatment. Surgical treatment, we have discussed 4 types. Hearing aid can also be used. Tinnitus maskers can be used, and psychological treatment. So this is the topic. So that was the class today. And if you have any doubts, or if you want to want some repeat of any topics, kindly note it down and please make a list of the topics which I have covered, and just compare it with your textbooks. If any of the topic is left, please let us know by tomorrow evening, so that we can prepare for the next classes. And or else we'll start with the surgical topics, and then we'll follow it with revision. So class Prakash and all, if you kindly inquire all of your friends, and if any of the topic is left, please let us know, then we will teach accordingly. If everyone has marked your attendance, then I'm closing the class. Okay, thank you so much. If no, some of you have not marked, then please mark it now. I'm closing it.